Good morning, and welcome to Talks at Google in Cambridge, Massachusetts. Today, it's my great pleasure to introduce Dr. Angelo Volandes. He joins us today to discuss his new book, The Conversation, A Revolutionary Plan for End-of-Life Care. Dr. Volandes believes that a life well lived deserves a good ending. Through the stories of 7 patients with very different end-of-life experiences, he demonstrates that what seriously ill people who are approaching the end of their lives need most is not new technologies, but one simple thing, the conversation. He argues for a radical re-envisioning of the patient-doctor relationship and offers ways for patients and their families to talk about this difficult issue to ensure that patients will be in charge of their medical care. Dr. Volandes is a physician and researcher at Harvard Medical School and Mass General Hospital. He's the co-founder of Advanced Care Planning Decisions, a nonprofit organization devoted to encouraging the conversation through the use of videos. Please join me in welcoming Dr. Volandes.
So good morning. Thanks a lot for coming. I really appreciate it. It's a real privilege to present some of the work that I do, and especially here at Google, because you all tackle some of the most difficult problems facing our society. And what I'm going to talk about today is what I feel is the most urgent problem in healthcare today. So maybe you can help me think about it. When we asked most people where do they want to die, where do they tell us? Home. Most Americans want to die at home. In fact, in the latest survey, 86% of Americans want to die at home, surrounded by their loved ones, and in comfort. But what are the facts? Where do most people die in our country today? Hospitals. People over the age of 65, 2/3 of them will die in a hospital or nursing home, often tethered to a machine and in a good deal of pain and suffering. This misalignment between the type of medical care people want and the type of medical care they end up getting in our healthcare system today is what I feel is the most urgent problem in healthcare. Now, you've all been reading about it. On the front page of the New York Times, there's been a story about the problem, and we usually talk about it in terms of cost. Yes, end-of-life care is indeed costly, but by the end of our time together, I hope to throw in 2 other phrases, 2 other lenses from which to understand this problem. When Americans get care in hospitals that if they were more informed, they would not want, let's call it for what it is. It's unwanted care. And when people get unwanted care in our healthcare system today, it's truly a medical error. It's no different than a surgeon operating on the wrong side of the body or an ICU doctor not following a checklist for a patient on a breathing machine. But we don't want to just talk about problems. What are some potential solutions? For me, I feel that the primary reason why people get unwanted care in our healthcare system today is because doctors are not slowing down, sitting down, and having the conversation, an honest and frank discussion with patients and family members about what's important to them. But you know, today we live in a visually literate society. We're a YouTube generation, and that's true of all ages. And sometimes words are not enough. Sometimes we need images to help people better understand their options. So I'm also going to talk about how to enhance those conversations with videos. But before I get started, I thought I'd begin with a story. This is, after all, a book reading. Meet Professor Helen Thompson. Helen Thompson was one of the foremost literary critics on the poetry of Walt Whitman. How many of you are familiar with the poetry of Walt Whitman? Great. So there's definitely a generational gap there. I was born and bred in Brooklyn, New York. You'll hear my accent occasionally, where Walt Whitman spent the first half of his life. So every other street corner had a Whitman elementary school, and all the pupils were forced to memorize the opening lines of Whitman's magnum opus, the leaves of grass. So Professor Thompson and I hit it off because we could both recite those lines. I celebrate myself and sing myself, and what I assume you shall assume, for every atom belonging to me as good belongs to you. Now you may be asking yourself why I'm telling you about Helen Thompson or the poetry of Walt Whitman. Well, what I haven't told you is that Helen Thompson was my patient a few years ago. What I haven't told you is that Helen Thompson was a 56-year-old female with brain cancer being admitted to my hospital service. What I haven't told you is that Helen Thompson was dying. And so I conducted a history, I did my physical exam, and then I got to that point where doctors get a little bit uncomfortable with, where the words of Whitman metamorphosed into other words. Words like CPR, ventilators, the ICU, goals of care, hospice. In other words, the vocabulary of shared decision-making at the end of life. And I looked at the professor and I said, Professor, you've seen scores of doctors since you were diagnosed and by the time that you're seeing me. Have you ever had the conversation with them? And she gave me that blank stare. And so I proceeded to ask her those questions. What's important to you? What's a good day for you? Where do you want to spend whatever remaining time you have? Where are you on this journey with your illness? And then she looked at me and gave me that blank stare that I think a lot of patients give doctors when they have this conversation. And so I naively asked her, I said, Professor, would you take a walk with me to the intensive care unit so I can actually show you some of these things? Of course, she obliged. We didn't walk to the ICU. I put her in a wheelchair and rolled her down to the intensive care unit. I got to show her a ventilator. I got to show her a patient on a breathing machine. There were a couple of residents there. One was performing a lumbar puncture. Another one was inserting a central line. And what the professor was able to do was to get a sense of the place, hear the beeps and buzzes, see the colorful monitors, to feel the rhythm of the intensive care unit. Now, as fate would have it, I obviously did not plan on this, but there was a code blue in the ICU while we were there, and I immediately brought her out of the intensive care unit, but not before she caught a few glimpses of CPR. When we went back to her room, she looked at me and said, words, words, words. Angelo, I understood every single word that you said before. CPR, breathing machines, comfort care. I am, after all, a professor of English. But I had no idea that's what you were talking about. Doesn't look like that on television. And that's when it occurred to me, so often in healthcare, we're having these conversations with our patients and family members, but they're thinking about what's on the television and that CPR works all the time and that everybody looks like George Clooney on a breathing machine. The clinical reality is very different. So what I decided to do was to take my next 6 patients, all with a serious illness, and their families on their own personal tour of our hospital. Some patients I brought to our intensive care unit. Other patients and families I brought to our dialysis unit. And what every person told me was that this was the most powerful and empowering experience that they had ever had, that they couldn't imagine making a decision about end-of-life care without this tour. Now, although the nurses loved what I was doing, they could see the educational value in it, they quickly put an end to my tour business because they knew I was breaking patient confidentiality. So here's the conundrum that I was left with. How could I recreate this powerful and empowering experience for both patients and families and yet not break patient confidentiality? And that's when I came up with the idea. Why not create short films to help people better understand their options? So it's not just me, it's a group of around 100 of us. We are 100 doctors, nurses, patients, families, and video artists from 10 academic medical centers who create these short videos, but we don't just create them, we actually study them in rigorous randomized controlled trials. And there's three things that we find. First, for patients who have a serious illness and watch a video, they're more informed about their options. They have much more knowledge with which to understand their medical options. The second thing is that for people who have a serious illness, who have a conversation and use a video, they actually tend to want more comfort-oriented care. They make decisions that lead them to end-of-life care outside of the hospital, not tethered to machines and not in our intensive care units. And the third thing is, when we ask people, are you comfortable watching a video about goals of care at the end of life? People are overwhelmingly comfortable. We truly are a YouTube generation where people expect these images. If a picture speaks 1,000 words, videos speak hundreds of thousands of words. So what I thought I'd do is show you one of our studies. And it was actually our first study done right here at Massachusetts General Hospital with patients who had advanced cancer. So what we did is we took 50 patients, all with advanced cancer, and we randomized the group into two groups. The first group had a verbal discussion about what sort of medical care they wanted now that they had advanced cancer. We asked them, what would you want now that you have advanced cancer? And we gave them three options. The other half of the group had the same verbal discussion, but then they saw a short video that actually showed them what each of their goals of care entailed. Now, I know most of you are not clinicians, but let me just give you the general flavor of the goals of care. This is available anywhere in America today. You generally have three options: life-prolonging care, limited care, and comfort care. And I'll briefly review each one. With life-prolonging care, the goal is to prolong life. It includes anything available in a modern-day hospital: CPR, breathing machines, the intensive care unit. The middle category, limited care, is essentially hospitalization without the ICU, without CPR. And the third category, comfort care, is essentially symptom relief, really hospice-level care. So those are the options that all 50 patients had. But for the patients that were randomized to the video, they got to see visual images of each of those categories of care. Now, the particular video that we created for these patients was a 7-minute video, and it was filmed and developed with an expert panel of over 50 oncologists, intensivists, palliative care doctors, nurses, social workers, chaplains, patients with advanced cancer, and the families of patients with advanced cancer. We wanted to make sure that we offered a fair and impartial portrayal of what the options were for patients. Now, dealing with 50 people, we bent over backwards to make sure that we addressed everybody's concern. But you know the joke about getting a bunch of oncologists together and asking them an opinion on a patient, you'll get 50 different opinions. This video took us 2 years to make. Steven Spielberg makes probably 5 films in 2 years. But we wanted to make sure that patients and providers felt that this was a fair and impartial portrayal. I'm Angelo Volandes, a physician at Harvard Medical School. Thank you for taking the time to read the conversation. It's been a privilege caring for patients. Thank you for hearing their stories and bearing witness. In this video, I'll be covering some of the topics that I touch on in the book, so make sure to refer to the book for more details and information. Talking about medical care at the end of life can sometimes be difficult, but it doesn't have to be a sad conversation. There's a common 3-step approach to do it well. The 3 steps are: start the process and have the conversation. Talk to your loved ones about your values and what's important to you. And then, talk to your healthcare team about your medical choices. Let's review each one of these steps so you can make sure you get the right care at the right time and on your own terms. Don't wait for your doctor to start the conversation. Start the discussion on your own with family and friends. Here are 4 questions that can help start the process. What kinds of things are most important to you? What concerns do you have about getting sick or needing medical care? If you were very sick, are there any specific medical treatments that might be too much for you? And finally, what are your spiritual, philosophical, religious, or cultural beliefs that would influence your medical decisions? Considering these questions is only the beginning. These reflections are not a one-time event, but a process that you should return to over time. After you've thought about your values and wishes, it's important to share your information with your loved ones. Holidays are a good time to start having these discussions with the people you would want to be around if you became very sick. Pick a calm and quiet place to talk. The talk doesn't have to have a certain structure, let it just happen. And you don't need to establish everything with one conversation. After the conversation, I often tell my patients to use their cell phone or tablet to film themselves telling their loved ones what is most important in their lives regarding medical care. They can then send the video to them. And if you are ready, complete the appropriate legal paperwork. Now you're ready to complete the last step, talking with your healthcare team. Talking with your doctor is vital, since he or she will know your medical condition best and will be able to help translate your preferences into an actionable medical plan. There are 3 general approaches to medical care for people who are very sick. They are life-prolonging care, limited medical care, and comfort care. The first approach is life-prolonging care. With this option, the focus is to lengthen life. This includes all medical care that is available in the hospital, like CPR, breathing machines, and treatments in the ICU. For healthy people, CPR has a good chance of success and has improved over time. However, for people with an advanced illness, CPR's overall effectiveness is not high. It's important to ask your doctor what the chances are that CPR will work in someone like you. Sometimes, people decide to try life-prolonging interventions for a short period of time, and if the interventions are not successful, they move to the next option, limited medical care. With limited medical care, the focus is to take care of treatable problems. People who choose this approach want medical care that will help restore their health. My father received limited medical care. He had IV medications with careful monitoring. But he did not want any life-prolonging interventions like CPR and breathing machines. He chose to avoid these procedures even though he might have died without them. The third approach is comfort care. With comfort care, the main goal is to be comfortable. Treatments are only used if they help make people feel better and improve their quality of life. People who choose this approach are usually treated at home, in hospice, or sometimes in a nursing home. Talk to your doctor and your loved ones. If you let them know your choices, they can help make sure that you are at the center of and in control of your care. Thank you for taking this journey with me and hearing the lives of some extraordinary people. Their stories are our stories. Take care. What did those 50 patients, what were their decisions? So let's take a look at the group that only had a verbal discussion. In yellow, we have life-prolonging care. In blue, we have limited care. And in green, we have comfort care. So why don't you take a guess of what you think people wanted? Charles, what do you think people in the verbal arm felt? What percentage wanted life-prolonging care? 65% wanted life-prolonging care. This is what we found. 26% in yellow wanted life-prolonging care, 52% in blue wanted limited care, and 22% wanted comfort-oriented care. I'll be honest, I admit these patients to the hospital all the time. I wasn't surprised by this. the patients that I admit to the hospital with advanced cancer, I'd say a quarter want life-prolonging care, a quarter want comfort-oriented care. Half of people are somewhere in between. Well, what happened to the group that actually saw the video? The gentleman with the green t-shirt. What do you think?
A sharp decline in life-prolonging care and shifting down to comfort care, so call it 10, 40, and 50.
A sharp decline in life-prolonging care, an increase in comfort care, 10% life-prolonging care, 40% limited care, and the rest comfort care. Well, let's take a look at what our patients chose. A dramatic difference. The interesting thing was that the people who saw the video also had more knowledge. We actually quizzed them, and they answered many more questions correctly after watching the video compared to patients who did not watch the video. So what this told us was, if you saw the video, you had more knowledge, and you were more likely to choose comfort-oriented care. Now, to be clear, when we have verbal discussions today, what happens? Most people still end up dying in our hospitals. 2/3 of folks are dying in our hospitals. That's what's going on today. But can we imagine a time when people are more informed, where they have the conversation, they have a video that explains their options and standardizes the process? What happens then? Most people die outside of the healthcare system, surrounded by their loved ones and in comfort. This is the medical emergency of our lifetime in the healthcare system today. We are delivering unwanted care every single day in our hospitals and nursing homes across the country. It's a medical error. So this study was done close to 7-8 years ago. Since then, we've done many studies, and the interesting thing is we're seeing the same things. So I'm just going to give you a quick glimpse of what some of our other work shows. We asked 200 elderly people what sort of medical care they would want if they had advanced Alzheimer's disease. And we did the same study, randomized control trial. Half of them had a verbal description. The other half had a verbal description plus saw a video. Here's what the group that only had a verbal description, this is what they told us. 19% wanted life-prolonging care, 17% wanted limited care, and 64% in green wanted comfort care. What happened to the group that had the same verbal description and then saw a video? A very different picture emerges. 86% of people wanted comfort-oriented care. We even went to a primary care clinic and did the same study, asking people, if you had a serious illness, what sort of medical care would you want? In the group that only had a verbal discussion, 72% of people wanted comfort-oriented care. Add the video, and all of a sudden, that jumps up to 91% of people. Not a single person wanted aggressive, life-prolonging care. We even went to nursing homes, and this is something really near and dear to my heart, because I'm not only a doctor, I'm also a son who's dealing with this with his parents as we speak. So let's take a look at a nursing home. Same study, half of people were asked, how do you want? What are your goals of care? How do you want to spend the end of your life? In a skilled nursing facility right here, these were 2 facilities right here in Boston, 57% wanted comfort-oriented care. What happens when people actually watch a video that explains to them what their options are? That number increases to 80%. But even that wasn't enough. We went to our medical ICU right here at Massachusetts General Hospital, and we asked not the patients because they were too sick. In fact, all the patients were intubated. They were on a breathing machine. So we asked their families to make a decision about CPR. And these were all critically ill patients who had a terminal diagnosis. And this is what the families told us about CPR when we described to them the procedure. 78% of people in red wanted CPR attempted on their loved ones. What happens when you actually show people what CPR involves? That number drops to 41%. We live in a healthcare system that does not do a good job of communicating with patients and families. And we've now done trials in over 2,000 people all across the country. But it's not enough to show that people are more informed with videos or to show that they make decisions about comfort-oriented care. You have to show that people actually like the videos. So we asked all 2,000 subjects, what'd you think about the video? This is what people told us. 90% of people who viewed the video found it helpful. But were they comfortable watching the video? 93% of people were very comfortable watching the video. And then I think the gold standard question as a doctor is asking my patient who's seen the video, would you recommend this to your mom or dad or to a sibling who has to make a similar decision? 97% of people said they would. When did 97% of patients ever agree on anything? These are really high numbers, as you can imagine. You know, I think it just speaks to the fact that we are a visually literate society. Our patients and families are now expecting this. So I could have stopped and done my research. I would have gotten, on my way to getting tenure at Harvard Medical School, wonderful. Sit on my, derriere at Massachusetts General Hospital. But our group didn't want to just make publications. We didn't want to have this work really just in libraries and read by a bunch of doctors. We are interested in transforming healthcare. So 3 years ago, I co-founded, along with another colleague who's both a doctor and a lawyer, we co-founded a nonprofit foundation whose mission is to transform healthcare across the country by using videos. And as of today, there are 200 hospitals, clinics, nursing homes, hospices, and healthcare systems across the country in nearly 25 states who use our videos to transform the medical culture in their healthcare system. Think Khan Academy, but for medicine. And it's probably the most exciting work that I do because for too long, we've just been talking about the problem. We haven't been posing solutions to what to do about this unwanted care in our healthcare system today. Now, our library of videos has exploded. We have over 60 videos because we not only make videos for the leading causes of death, cancer, heart failure, dementia, but also in all the languages that represent our diverse community. So we have videos in Spanish, Cantonese, Mandarin, Japanese, Korean, Vietnamese, Tagalog, Ilocano, Marshallese, even Samoan. Because what we're trying to do is to meet people where they're at. Our latest series of videos are actually in Persian because we found a great need in the Persian community to actually make sure people understand their options. But I know we're at Google and it's all about data. So we are also interested in big data. And what we wanted to ask is, do these videos actually make a large difference? Sure, you could try to attack 200 hospitals and clinics across the country, but what about an entire geographic area? So our nonprofit is now involved in one of the largest projects in America when it comes to end-of-life care. And what we've decided is to blanket an entire state, the wonderful Aloha state of Hawaii, where all 1.4 million residents have access to all of our videos. Over the course of 3 years, we're about halfway through, every single resident of Hawaii has access to the videos. 15 hospitals, 50 skilled nursing facilities, 10 hospices, over 600 providers. Regardless of your insurance, regardless of where you're seen in the entire state, you have access to a video in your language that will allow you to understand your options. And what we're doing is using very large databases to see over the course of 3 years, what happens to hospitalizations? What happens to the number of deaths in the hospital? What happens to number of days in the ICU before people die? And we're gonna use those metrics to see, can a video and prioritizing the conversation at an entire statewide level, can you really transform healthcare? We've already started getting the data, and I'm pleased to say that indeed we're seeing transformation already. In fact, 4 other very large states are interested in replicating what we're doing in Hawaii, because that's what this is all about. It's making sure that patients get the right care at the right time, but on their terms. Today, although we say we live in a patient-centered healthcare system, I think many of you know we don't live in a patient-centered healthcare system. We live in a clinician-centric healthcare system where people end up getting care that if they were more informed, they wouldn't want. Now, before I end, I thought I would tell you about my own journey to this work. And so I thought I'd just take a 10-minute book reading, since we are at a book reading, of telling you about my very first patient. Taras Skripchenko was a living part of American history. As I later found out, Taras was an ethnic Ukrainian who had emigrated to the United States from the Soviet Union as an adolescent. He was one of the lucky few who escaped the chaos that took over during the months before World War II. Taras wanted to start over, to rewrite the opening chapters of his life. At 18, he found a new home in a Ukrainian enclave in one of the mining towns of Appalachia, and quickly found labor in the coal mines. For years, he led a life of unremitting physical toil, working 12-hour shifts, 6 days a week. Unfortunately for Taras, a lot of the detritus from smashing coal dug its way deep into the lining of his lungs, plugging the airways. It would also plant the creeping cancer that would devastate him decades later. This once hulking mine worker had dwindled to a mere whisper of his former muscular self. This frail, bed-bound 78-year-old with inoperable lung cancer was admitted to my medical service during my first year of residency training. Slowly suffocating to death, he experienced both transient moments of hallucinatory joy and unconscious yet peaceful somnolence on the oncology ward. Taras was too confused to have a lucid conversation and lacked family members to guide his decision-making, so his medical plan was the default approach for all patients: do everything. Despite my efforts to come up with a plan for Taras, I knew that his cancer surely had a plan of its own. Doctors can fool themselves into thinking that they are in charge, even when disease and pathology are in the driver's seat. Frequently, we are only along for the ride. Taras was dying. I knew it, and the nurses knew it. But as far as the medical team was concerned, Taras was a full code. If his heart or lungs stopped working, we would attempt CPR and place him on a breathing machine. Exhausted from a long day, I paged the overnight resident to meet me in the cafeteria to review my patients before I signed out. The overnight doctor was a senior resident named Edward, and I was glad an experienced resident was on call that night. I told the resident to keep a close watch on Taras Skripchenko. He's a Ukrainian gentleman. He worked in the coal mines of Appalachia. About 8 months ago, he started having a cough. He saw his primary care doctor, who ordered a chest x-ray. Stop right there, Edward said. Start again. Start with initials. And then in one line, give me the pertinent info. Less is more. I have 30 other patients to cover tonight. When a resident is responsible for 30 patients at night, too many personal details can muddle one's thinking. T.S. is a 78-year-old male patient with metastatic lung cancer who presented with shortness of breath and delirium. I said, he's really sick. Modern medicine can be dehumanizing, and the first step in that process is to remove all the individualized details, to obliterate personhood and replace it with patienthood, where 2 letters are a patient's diagnosis, treatment, and prognosis. Code blue, code blue. Edward and I sprinted towards the oncology ward, racing through the obstacle course of stretchers and patients. We finally arrived out of breath at Taras' room. I was always taught to hope for the best, but prepare for the worst before entering a patient's room. But it's not always clear how to define the worst. The gathered nurses who had ordered the code blue had already started CPR. I clumsily jammed my hands into a pair of rubber gloves and joined the ritual, relieving one of the nurses doing chest compressions, which is far more physically demanding and brutal than what is portrayed on television. My clasped hands pressed hard against Tatas's frail chest, and all I could hear and feel were the cracking of his ribs with practically each chest compression. The rhythmic pumping on his chest eerily emitted a coarse, Velcro-like sound. Edward stood at the foot of the bed and took charge, directing what was likely to be Tatas's passage from life. I searched for a pulse on Tatas's neck. Any fat had melted away long ago, and all I could feel was cartilage and windpipe. It's an eerie feeling, sliding bloody gloved fingers along the skin, searching for signs of life. Shockingly, I found only a thready pulse, one that lacked vigor. Taras was stabilized. He was connected to a breathing machine and had a pulse with a normal rhythm. The team had saved the patient, and now it was time to transfer him to the ICU. Edward and I bundled Taras and his machines onto a gurney and navigated the labyrinth of hallways to the elevator. We squeezed into the narrow elevator as the doors closed. I kept my hand on Tatas's carotid artery, making sure to feel for a pulse, until I realized he no longer had one. There was no space alongside the gurney, so I jumped on, straddled him, and started performing chest compressions. In all likelihood, the cancer had spread to the thin sac around his heart, allowing blood and fluid to seep in and surround the vigorously pumping heart muscle. To get the heart beating again, a doctor must emergently stick a large needle into the patient's chest and draw out the fluid. We needed to move fast. "Do you feel comfortable doing this?" Edward asked. I told him that I had performed the procedure on a cadaver in anatomy class, but had only seen one on a patient. "See one, do one, teach one. Here's your chance on a warm body," he rejoined, as the elevator doors opened to a crowd of nurses ready to wheel the patient towards the ICU. I descended from the gurney. Edward handed me a large syringe attached to a needle the length of my ring finger. I stared at the needle. My hands were shaking, not surprising since I was about to poke around a man's heart with a needle. You don't know how deep to slide the needle into the body in order to draw out the fluid from the sac surrounding the heart. Every body is different. Some are fatter than others, and some are more muscular than fat. I pierced Taras' skin just below the sternum and carefully pushed the needle through the skin, simultaneously pulling back on the syringe, hoping to see fluid. No luck. The tremulousness in my hands worsened, and beads of sweat trickled down my forehead, falling onto the syringe. I advanced the needle a little more, but no luck. I pulled the needle out and tried again and again and again. By the fourth time, I gave up. Residents are usually allowed 3 strikes before being asked to stop. Edward gave me a 4th since this was my patient. I probably should have stopped after the 3rd. Taras' ribcage had become a pincushion from all my attempts. As soon as we entered the ICU, Edward filled in the medical team as they took over, using the ultrasound machine to remove the liquid surrounding his heart. Taras' once flailing heart could beat again. He had a pulse. Taras' care was now being managed by the ICU team, so Edward and I headed back to the cafeteria to grab some coffee. After every code blue, the team is expected to review what transpired. It's a ritualized moment to grapple with the trauma surrounding a full-on code. Debriefings are always difficult moments, as each of us dials down the rapid pace of a code blue to digest the events that have just transpired. We sat quietly for a few minutes. We reviewed the running of the code, how each team member had performed his or her duties. We replayed each of the interventions I had performed and discussed how I could improve my technique for the next time. Silence settled again once the routine items were out of the way. but there was more to be said. We just completed a by-the-book code, but I wonder if we did the right thing, I said, needing to tell Edward what was on my mind. Perhaps it was because I was a young doctor and I had not yet been numbed to the brutal experience of caring for hundreds of patients. I hoped Edward, a more seasoned doctor, would have a better perspective. We did exactly what we were taught to do. Everything was by the book. Look, this is the system. We have a job to do, he said. But I could see a slight unease in his face, a hint of upheaval. We both knew something was not right. I can't believe we just did all that to a man who has one foot in the grave, I pushed, not mincing my words. Would he have wanted any of this? Would you have wanted any of this? Would you do this to your dad? Something is wrong with a healthcare system that puts terminal cancer patients through torture. Edward put a hand on my shoulder. It's going to be all right. You're still new at this. You'll get used to it. Get some sleep and page me tomorrow. Get used to this? Is one supposed to get used to this? Over the next 2 days, Edward and I followed Taras every few hours in the ICU. He was no longer our patient, but we could not let go of him either. By the following morning, he had a tube or catheter in almost every part of his body, a grand total of 8 plastic intrusions. Taras was fixed. Doctors like to tackle problems and fix them, and it is truly amazing what modern medicine has achieved in a relatively brief span of time. The tougher issue, however, is when to recognize that the small fixes do not change the larger picture, to recognize that fixing specific problems may not fix the whole patient. This is medicine's version of not seeing the forest for the trees. Doctors always search for the next fix, but we need to know when to use or not to use our growing toolkit of fixes. Taras's heart had stopped 3 more times, and miraculously, the ICU team had brought him back each time. But not surprisingly, a patient in the late stages of terminal cancer succumbed to his disease. Whatever the next new fix is, nature eventually takes her inexorable course. Taras died 48 hours after that initial code blue. Americans receive some of the best healthcare money can buy. They also experience some of the worst deaths in the developed world. The primary reason we experience such horrible deaths is doctors' failure to openly discuss medical care with seriously ill patients. Taras Skripchenko died 15 years ago. I have since witnessed hundreds of deaths, but his, which I experienced during the formative years of my medical residency, haunted me for the first decade of my life as a young physician. So too did that conversation with Edward, as we both struggled to make sense of the drama that had just unfolded before us. Today, I am a full-fledged medical doctor, a senior physician and teacher of others. Yet, I still think about Taras each time I meet a new patient. A new beginning, a clean slate, but also a potential TS. Thank you very much. So we have lots of times for Q&A, and what I was encouraged to do is to have you come on up to the microphones because this is being recorded. Yes?
Thank you for doing this very important work. I could ask a lot of questions, but let me ask one about data, basically. I'm interested in how you're actually measuring the outcomes of your video intervention. In the first series of studies you described those as randomized trials,
but the outcome you were measuring there was simply, as I understand it, just that people then told you what they would prefer. Now, in your Hawaii study, which you mentioned, obviously a much more massive study, you clearly are aiming to measure actual outcomes in terms of what kind of care these people got. But from the way you described it, it sounds like you're using more of an epidemiological model, that there is not a randomization component there. So I'm curious about how you're going to extricate the effects of your intervention from all the other stuff. Are you just going to use standard statistical techniques to do that? Or do you have an actual randomized component somewhere where you're actually looking at what the outcomes were and not just what people told you at the end of the studies?
What a wonderful question. I wish I had more time to tell you about all of our studies, but let me tell you about 3 that address that exact point. So just last week, a study was published in the Journal of General Internal Medicine, where we not only looked at what people told us, we actually looked at what happened over time through the electronic medical record. And we found 3 things which were fascinating. Again, same thing, randomized controlled trial. Half of people got the usual care at our hospital. The other half of people had usual care plus the video. And we actually found the following abstracted from the electronic medical record. People actually made real decisions after watching the video that was for not having the aggressive life-prolonging interventions. The other thing we found was there was actual documentation of doctors having the conversation and stating that they had the conversation, written documentation. But we went even one step further. We actually followed people for 1 year. And what we found was that patients in both arms, the first group that did not watch the video, I forgot the number of people, maybe 40 or something people, were readmitted to the hospital. And what we found was that 22% of people ended up getting an intervention that they never wanted, that they actually told us. What percentage do you think in the arm that saw the video got something that they didn't want? 2%. And that person was actually someone who had a procedure done and it was temporarily reversed. So what we have for the first time is hard data of real decisions of people showing exactly what the previous study shows. But that's not enough. I'm with you. That's a small study at 2 hospitals. What we're doing in Hawaii is the next step, which is we're doing a natural experiment. We actually know when we started in Hawaii in terms of the videos. So what we're doing at time 0, when the videos were started, and we know the penetration rates, it's not like all of a sudden everybody in Hawaii is watching the videos. It's graduated over time. So over the course of 3 years, 3 years is our point, at that point, we're actually going to compare hospitalization rates, hospital deaths, ICU deaths, chemotherapy in the last life, compared to 3 years before we started in Hawaii. Furthermore, we know what's going on in the state, so we will account for those through statistical methods. But even that is not enough. Our biggest project to date, which I didn't mention, is looking at a randomized cluster trial, which is called a pragmatic trial. This is all fancy words of just saying, instead of randomizing by the unit of the patient, why not randomize 600 nursing homes all across the country? Half of the nursing homes get usual care. That data is collected through a large database called MDS. And then the other half of nursing homes, the other few hundred, will actually get to use the videos after being trained and however they wish. And what we're going to do is to see over time those hard outcomes that we talked about. That's truly the randomized controlled trial that you're asking about. But we've moved beyond the data that I've shown, which is more of what do people tell us, to hard data, what happens? Because we feel that this work will truly transform care. We're using large databases now. We have the opportunity to do that. And I should mention that the nursing home study is actually funded by the NIH, the National Institutes of Health. Thank you for that great question. Yes?
Thank you for coming. So when you did you talked about the video showing the comfort level. When you talk with people in nursing homes about that, how does that they're in a nursing home, which is not at home with family and things. How do you do you adjust that, or how is that presented to them?
Wonderful question. And in fact, we developed a video for that study with the nursing homes just on this point. People don't realize just because you live in a nursing home, in a skilled nursing facility, if you're a resident there, what is the assumption of most people? Oh, I get sick, I'm going to go back to the hospital. That's not true. There are many things that could be done focused on quality of life and comfort-oriented care right there in the nursing home. And so people actually do have the option of hospice care at a nursing facility. It's one of the newer waves of what we're seeing in skilled nursing facilities, because let me tell you, as a doctor, and what I see here all the time is the revolving door of the hospital. We get a frail elderly person who's admitted to the nursing home. No one has had the conversation. No one has started the process of talking with the family. What's important to them? What do they want to focus on? And as soon as they get a fever, as soon as they become delirious, they're just, and I hate to use the word, shipped to the hospital. Call 911 at the nursing home, the ambulance comes, nobody has asked the patient or the family what they want, and they're brought to the hospital. That fix that we do in the hospital, antibiotics, get the patient back to where they were, and then they're shipped right back to the nursing home. It happens thousands of times a day, and it's because in nursing facilities, we're not having the conversation. No one's explaining to people what their options are, and that's the sort of disruptive nature of the videos. The idea behind the videos is that today, I'm the doctor, I have all the power. If we're going to talk about this, it's only because I raised this issue, and most of the time I'm not raising this issue. What we're hoping the videos do is empower patients and families so they know what their options are, so that they know what are the questions they should be asking themselves. This way, we're not relying on the healthcare system to bring up these questions. Patients and families are bringing up this question. And in fact, that study that I mentioned, what we found was that patients indeed were asking their doctors, hey, I just saw a video that mentioned my options for care. I want to talk about this with you. I have much more faith in relying on patients and families to raise this question by empowering them with videos than I do on the healthcare system. It's disruptive because it flips the power dynamic. And I hope that the video, which is on YouTube, it's at theconversationbook.org, I hope that people use it to empower themselves. Yes?
Thank you also for your work. 4 really short questions.
4 really short questions. Let's go one by one.
All right. Where can we get the videos? Can we get them online? 2, does it make a difference?
Oh, so the first question, theconversationbook.org, it's a short video. It tells you through all your questions and your options. Your second question.
Is the video without the conversation as effective as the video with the conversation?
Great question. What we've done in all of our studies is not only done the video in isolation. This is meant to supplement the conversation. So it's always been conversation, conversation plus video. And I truly feel that at the end of the day, videos are a tool. The answer and the solution is having that conversation with your clinician. It's just that videos help spark the conversation, as we saw in our study.
But you don't have any data on whether the video alone is as effective or close to.
So we don't do that intentionally because we don't want people to say, you know, I could envision my worst nightmare, what keeps me up at night, is a surgeon, I hate to say surgeon, who says, hey, go watch this video, tell me what you want. I don't want that. I got into medicine because I love talking to patients. I hope my colleagues feel the same. Your other question?
Okay, third question is, so do you routinely have the conversation at the revolving door now in your practice?
In my practice, absolutely.
Okay.
And what's remarkable is that it's not just me. I'm proud to say that not only in our healthcare system, but all around the country, what we see, and this is the work that the nonprofit does, is people are making this routine. It's changing the culture where part of the responsibility of being a good doctor, a good clinician, is not only asking what medications are you on, what are your allergies, and your past medical history, but let's sit down and talk about honoring and respecting your choices if you have a serious illness.
All right, and the last question is, did Edward change his mind about following the book? Did he question the book ever?
So that's a wonderful question. Edward is a dear friend of mine. Edward and I have both grown through that experience. In fact, part of our subsequent code, because we had many codes together, Edward and I looked at each other and we said, you know what? We're both committed to changing healthcare. And I'm very happy to say that Edward is one of our big supporters in our nonprofit work and actually has transformed care in the city that he's at. Thank you.
You talked about the effects, measuring the effects this has on what choices people make and on figuring out whether those choices are followed through on. Did you also measure how that actually affects length of life, quality of life, how their friends and family feel about what happened, and so on?
Yeah, what a wonderful question. So we are actually now, with our other studies, looking at those very important questions. What was the bereavement experience for the family? You know, we often focus what's happening on the patient, but remember, when the patient dies, it's the family that experiences that moment over and over. So we are looking at things like anxiety and depression on family members, what we call the bereavement experience. And the other ones that you wanted?
What effects it has on the patient's both length of life and quality of life, and how they feel about what happened.
Wonderful. So we actually are looking at survival. Look, slowly we're seeing research. In fact, the paper that one of the big papers on this came out of Mass General Hospital and my colleagues there, where they looked at people who chose early hospice care. And what they found in a randomized trial compared to people who did not choose hospice care was they actually lived longer. That's a new finding, and that's something we are publicizing. And what's happening is, this is what we think is going on. People actually live longer when they feel that they're in control of what's going on. But going to the hospital might be bad for you. Medical errors that we have in our healthcare system, whether it's infection rates or procedures that are performed on people who are critically ill, actually might lead to earlier deaths. This is a very controversial thing that we're trying to publicize about. And we tell people, do you know that in numerous studies now, people who choose more comfort-oriented care with a life-limiting illness actually live longer. And so we are looking at that with our studies. What happens to survival rates? What happens to those 600 nursing homes? What happens to folks who decide, I'd rather stay in the nursing home. I'd rather not get CPR or not get aggressive life-prolonging interventions. I want aggressive care, but I want aggressive care focused on my quality of life and comfort. We'll be following that, and it's really transforming what's going on in healthcare today. Thank you. Yes?
You stopped short of any discussion of actually assisting patients in their death process. Can you discuss that issue?
Why does this question always come up?
Because there's always someone like me.
There's always someone like you. Okay, so let's be clear. The book's about advanced care planning. It's about what affects every single person in our country today. It's about making sure we're honoring and respecting people's wishes. The issue of, I'm going to call it for the variety of things today, it's aid in dying, euthanasia, passive assisted suicide, whatever phrase you want to call it, is something incredibly different. I'm not a policy wonk. I don't understand all the issues, but I will say two things, because this question always comes up. It's complicated. It's really complicated. And I will say first, in our healthcare system today, for the vast majority of Americans, we are not meeting their needs for suffering and pain and control of their illness. And so the amount of resources that we have for hospice and palliative care services across the country is clearly inadequate. And so I'm really focusing on trying to make sure we have those resources, because the question that I always have is, if we actually meet people where they're at, if we actually gave them control to not be in pain and suffering, where they feel that they are truly at the center of care, I feel that a lot of the issues that come up during the debate about aid in dying will disappear. That's my personal opinion. But I think the issue of aid in dying is so complicated. I'm not an expert on that. I don't cover it in the book, I'm sorry. But I try my best to make sure that people understand that we do a horrible job in healthcare today on just meeting people where they're at when it comes to end-of-life care. Because it's not just, even though I call it end-of-life care, it's not end-of-life care. It's about good care. It's not about a good death. It's about good life. We're all going to die. I'm going to die someday. and every good life deserves a good ending. So that's where I want to meet people at. And I know that's an unsatisfactory answer. I'm asked it all the time. I try not to deflect it too much, but I think it's complicated. I honor and respect people who debate with me about this question, because I think every patient has a story. And I've been on this book tour now for a few weeks, and there's a lot of pain and suffering out there, and it's patients, but it's also family members, and everybody deserves to have their voice. We're just hoping the conversation and the videos help everybody have a voice at the table. Thank you very much. I really appreciate your time.